Thanks for having me here at first, and I can briefly explain to you the rationale for the tropical ACS trial. Basically, when we designed the trial, we also looked at the current guidelines, and the current guidelines for treating ACS patients, they mandate a uniform and potent platelet inhibition for a period of 1 year, which could be either prasugrel or could be ticagrelor. So basically there's nothing against that, but if you go to the landmark data of the trials and if you look at the Kaplan-Meier curves and how the bleeding risk and the thrombotic risk develops over time, you can see that the risk patterns, they definitely differ, and not at every time the risk for thrombosis and the risk for bleeding is essentially the same. And what you have at the very beginning is a very high benefit of potent platelet inhibition in the early phase of treatment. This is surely there. I'm not saying that all of the benefit is in the early phase, but most of the benefit is in the early phase. But the situation is completely different for bleeding. So bleeding, and this was shown in Plato landmark data, this was shown in Triton-TIMI landmark data, bleeding really is an issue on the long run. So it would be desirable to de-escalate treatment, to have the acute phase covered by a potent antiplatelet and then to de-escalate down to clopidogrel, because potent platelet inhibition might not be needed anymore on the long run. Finally, however, when you are doing this, I think you have to reflect that there is a substantial variability in the antiplatelet action of clopidogrel. And this is why we designed a trial that aimed to de-escalate but also reflected the variability seen on clopidogrel, and we therefore included platelet function testing in our trial. And we de-escalated very early, 1 week after discharge of ACS patients that had a biomarker positive ACS undergoing PCI. So the design of the study was a randomized trial, of course, a randomized trial that had a control arm that reflects current guidelines. So 1 year of potent platelet inhibition in ACS patients, this was the control arm. And we aimed to show non-inferiority of a de-escalation approach that has only 1 week of prasugrel and then a wash-in week, so to say, on clopidogrel and a platelet function testing on clopidogrel, showing non-inferiority for a combined clinical endpoint of MACE and bleeding events over a period of 1 year. It was an IIT, an investigator-initiated trial, and a randomized trial, of course, to get robust data. The key findings were that, in fact, a de-escalation approach guided by platelet function testing was as good as potent platelet inhibition for 1 year. So we were able to show that a short period of prasugrel, a switch over to clopidogrel, and a carry on with clopidogrel in the majority of patients was as good as a standard approach of potent platelet inhibition. We saw numerically less bleeding events in our study. However, this difference did not reach a level of statistical significance, but we reached our primary endpoint by highly statistical significance on showing non-inferiority of PFT-guided de-escalation. This is an important question, because our study did not aim to show a better way in terms of what was shown in big studies like Triton and Plato. We sought to find an alternative treatment way, and based on the experience in our institution, but also based on the experience from large registries, for example, Translate ACS, really a huge effort that was done in the US to show how many patients are de-escalated. I think it is relevant in clinical practice for around about 20% of patients. So 1 out of 5, and this is pretty much. This is relevant because of bleeding issues on potent antiplatelets. This is relevant because of side effects that happen on potent antiplatelet agents. The best example is the dyspnea issue on ticagrelor. And this also is relevant due to economic aspects, which is a matter in Eastern European countries, in Asia, in Russia, in South America. So we should look over Western Europe, and maybe we should look over North America. We should look at the whole wide world and realizing that the availability of potent antiplatelet agents is not there in all places. And it is relevant for these patients as well. To have a short phase that doesn't cost so much and then to de-escalate down to clopidogrel.